Hello, my name is John Longest, and I'm an associate professor of EMS at Chesapeake College. Many of the medications that we, as ALS clinicians, carry in our drug boxes have numerous indications. Often the route, dosage, and administration rate vary depending on the condition we are treating. It can be a daunting task to remember the appropriate medication to administer, as well as the various dosages and modes of delivery. As you look through the pharmacology section of the 2025 protocols, you will notice changes to the dosing of several ALS medications. These changes have been made to reflect current best practices, as well as to simplify your job of determining the correct medication administration for your patients. In this module, we will discuss changes to the pharmacology for calcium chloride, dexamethasone, droperidol, and TXA. We'll start with calcium chloride. Calcium chloride is used to treat a variety of conditions. Indications include hyperkalemia, hypocalcemia, calcium channel blocker overdose, hypotension secondary to diltiazem or verapamil administration, and respiratory depression, decreased reflexes, flaccid paralysis, and apnea secondary to magnesium sulfate administration. In the past, the rate of administration as well as the dose vary depending on the indication. In the 2025 protocols, you will still see slight variation in the dose, but the rate of administration was standardized to 3 to 5 minutes for consistency. The adult dosage for hyperkalemia, hypocalcemia, and calcium channel blocker overdose is 0.5 to 1 gram slow IV push or IO over 3 to 5 minutes with a maximum dose of 1 gram. And for hypotension, following diltiazem or verapamil administration, or for adverse effects due to magnesium sulfate administration, the dosage is 500 milligrams, slow IV push, or IO, over 3 to 5 minutes. Pediatric dosage for all indications is 20 milligrams per kilogram or 0.2 milliliters per kilogram, slow IV push or IO, over 3 to 5 minutes with a maximum dose of 1 gram. Next, let's take a look at dexamethasone. You will recall that the indications for dexamethasone are moderate to severe asthma or COPD exacerbation, croup, and anaphylaxis. In the 2025 protocols, the maximum dose has been increased from 10 milligrams to 15 milligrams. This change reflects dosing recommendations in the medical literature. The preferred routes of administration, based on the specific indications, remains the same. For all indications, adult dosage is now 15 milligrams IV, IM, PO, or IO with no repeat doses. If an IV has already been established due to the patient's condition, the IV route of administration is preferred. Dexamethasone may also be given by the IO route if the IO has already been established to give other life-saving medications. However, an IO should not be established for the sole purpose of giving dexamethasone. Pediatric dosing is 0.5 milligrams per kilogram, PO, IM, IV, or IO to a maximum of 15 milligrams. There are no indications for repeat doses. For asthma, the PO route is preferred. For mild to moderate croup, PO route is preferred, but for treatment of severe croup, the IV route is preferred. If an IV is unavailable, the IM route may be used. For anaphylaxis, IV is the preferred route, but IM may be used if an IV is unavailable. Dexamethasone may also be given by the IO route, but only if it has already been established to give other life-saving medications. An IO should not be established for the sole purpose of giving dexamethasone. Moving on to droperidol, indications for droperidol are moderate agitation due to suspected psychiatric emergency, such as schizophrenia, or medical delirium with moderate agitation. Moderate agitation is defined as behavior that puts the patient or clinician at risk for harm. Droperidol is also indicated for nausea and vomiting. Droperidol is the preferred treatment for nausea and vomiting secondary to migraines, cannabinoid hyperemesis syndrome, or a patient's stated history of cyclic vomiting syndrome. For nonspecific causes of nausea and vomiting, droperidol is indicated in cases when symptoms do not improve after the first dose of ondansetron. The first change you will notice is in the adverse effects section. Previously, a medical consultation was required to administer diphenhydramine for a dystonic reaction after the dose of droperidol. In the 2025 protocols, you will find that the consultation requirement has been removed for both adult and pediatric patients. The other change in the droperidol pharmacology is the addition of the intramuscular route as an option for administration in treating nausea and vomiting. This provides consistency in the routes of administration across all of the indications. Let's review the droperidol dosages. For moderate agitation, adults 18 to 68 years of age should be administered 2.5 milligrams IM or IV. The dose for adults 69 years old and older is 1.25 milligrams IM or IV. Pediatric patients who are 13 to 18 years of age may be administered 2.5 milligrams IM or IV. Droperidol is contraindicated for treatment of moderate agitation in pediatric patients less than 13 years of age. A medical consultation is required for additional doses beyond the first dose for all age groups. For nausea and vomiting, adult patients with nausea and vomiting secondary to migraines, cannabinoid hyperemesis, or a stated history of cyclic vomiting syndrome may be administered 1.25 milligrams of droperidol IM or IV over 2 to 5 minutes with no repeat dose. If symptoms persist after droperidol administration, you may administer ondansetron. For adults with nonspecific nausea and vomiting that persist after ondansetron administration, you may administer droperidol 1.25 milligrams IM or IV over 2 to 5 minutes with no repeat doses. Droperidol is contraindicated for the treatment of nausea and vomiting in patients less than 18 years old. Finally, we come to TXA. Indications for TXA are suspected hemorrhagic shock due to a traumatic mechanism that has occurred within the past 1 hour and meets age-specific blood pressure criteria. Postpartum hemorrhage with ongoing blood loss despite uterine massage, with delivery having occurred within the past 1 hour and meeting age-specific blood pressure requirements. One of the listed adverse effects of TXA is hypotension. In the past, clinicians were cautioned to administer TXA slowly over 10 minutes to avoid possible hypotension due to rapid administration. Current best practices indicate that TXA can safely be administered over a shorter time frame. With this in mind, you will find that in the 2025 protocols, TXA may now be administered over 3 to 5 minutes for all indications. The new dosages are now, for patients 12 years of age and older, administer 1 gram of TXA in 100 milliliters of an approved diluent over 3 to 5 minutes. For patients 5 through 11 years old, administer 500 milligrams TXA in 100 milliliters of an approved diluent over 3 to 5 minutes, and for patients less than 5 years old, a medical consultation is required. Approved dilutants for TXA include normal saline, lactated ringers, and D5W. You are treating a 75-year-old female patient with symptomatic atrial fibrillation. You have an IV established. After administration of diltiazem, she has become hypotensive with a systolic blood pressure of 82. You have administered lactated ringers, but the patient remains hypotensive. Your next step should be A, administer 1 gram of calcium chloride IV over 10 minutes. B, administer 500 milligrams of calcium chloride IV push over 3 to 5 minutes. C, administer 20 milligrams per kilogram calcium chloride at a rate of 50 milligrams per minute. Or D, administer 1 gram of calcium chloride IV over 3 to 5 minutes. The correct answer is B, administer 500 milligrams of calcium chloride IV push over 3 to 5 minutes. A 3-year-old female patient is presenting with a barky cough, stridor while at rest, and mild shortness of breath. She is alert and sitting calmly on her mother's lap. She is showing no signs of respiratory distress or agitation. Her mother tells you the patient has had similar episodes in the past, each time she was seen in the ED and treated for croup. The correct dosage and preferred route of administration of dexamethasone for this patient is A. 0.5 milligrams per kilogram PO to a maximum dose of 10 milligrams. B. 0.5 milligrams per kilogram PO to a maximum dose of 15 milligrams. C. 0.5 milligrams per kilogram IV to a maximum dose of 10 milligrams. D. 0.5 milligrams per kilogram IV to a maximum dose of 15 milligrams. The correct answer is B. 0.5 milligrams per kilogram PO to a maximum dose of 15 milligrams. Okay. A 25-year-old male patient is complaining of a migraine with severe nausea and repeated vomiting for the last 5 hours. You decide to administer 1.25 milligrams of droperidol. Appropriate routes of administration include which of the following? Choose all that apply. A. PO. B. Intramuscular, IM. C. IV. Or D. IO. The correct answers are B. IM and C. IV. You are at the scene of an MVC treating a 60-year-old female patient who has obvious bilateral femur fractures and an apparent pelvic fracture with crepitus and severe pain on palpation. Her blood pressure is 78/43, her pulse is 126, and her skin is pale and clammy. The collision occurred 30 minutes ago. You are administering small boluses of lactated ringers. You are preparing to administer TXA and have mixed it with 100 milliliters of an approved diluent such as normal saline, lactated ringers, or D5W. The correct dose, routes, and rate of administration are A. 1 gram IV over 10 minutes, B. 500 milligrams IV over 10 minutes, C. 1 gram IV over 3 to 5 minutes, D. 500 milligrams IV over 3 to 5 minutes. The correct answer is C. 1 gram IV over 3 to 5 minutes.